Good morning. Thank you very much, LACNETS, for having me. I'm super happy to be here talking about imaging of neuroendocrine tumors. I have no disclosures related to this topic. So this is the overall outline of my talk. I'm going to start with anatomic imaging, CT and MRI, and then go on to PET images to talk about Dota-tate PET and also Fdg PET. So if you're a patient living with neuroendocrine tumor, you most likely heard the term of multi-phase CT or multi-phase MRI. So what does multi-phase actually mean? And why is it important in neuroendocrine tumor imaging? Well, typically, most of CTs we do for most indications are done in the venous phase. And this is the phase that I'm showing right now to the left side of the screen. So it is helpful for most of our indications, but for neuroendocrine tumors specifically, these tumors enhance quickly and early on. And what that means is that they take up the dye very quickly, and by the time we get to the venous phase, most of them have washed out already. So that's why we need the arterial phase to be able to catch them. So in this case, on the right side of the screen, you see these couple of lesions that are bright. So they took up the dye very quickly on the arterial phase. And if you look on the left side of the screen, we don't see them on the venous phase, which is our standard phase for most imaging. On the other hand, because a lot of neuroendocrine tumors are heterogeneous, some of them do actually show up on the venous phase, and those are the ones that are pointed to by the blue arrow. So you see how it's important to get both phases to be able to have an accurate evaluation of liver metastases in neuroendocrine tumors. And this is true for pancreatic lesions as well. So this is a patient who got a CT for a totally different, unrelated indication. And then when we were looking at the pancreas, we suspected that there is some fullness there. So if you squint, you kind of see a lesion in the pancreas. But when we further evaluated with earlier phases, with arterial phase, now you could see much better this bright enhancing lesion. And there are a couple more lesions that you see in the pancreas additionally as well that we did not see on the venous phase. So that's why in the evaluation of neuroendocrine tumors on the pancreas and liver, which both are in the abdomen basically, we need multi-phase imaging with arterial and then venous phase. Now, how about the small bowel? So the small bowel is really tricky, even for the trained eye. So and that's why they can be missed initially on imaging until they grow further. So even for a trained radiologist looking at this CT, for example, there is a lesion in the mesentery that looks exactly like the bowel that is difficult to see. Now, on the arterial phase, we see it better. We see that there is this lesion in the mesentery, and the primary is in the small bowel. It's a very tiny primary. It enhances on the arterial phase. And then the importance of detecting those early on is that even when they're so small, they could actually cause metastatic disease. So this very tiny primary that we see here in the small bowel is already, which is we see right there in the small bowel, is already metastasized to the liver, and look at how many liver lesions there are. So that's why the small bowel neuroendocrine tumors are tricky, and they could go undiagnosed for a certain period of time before they actually get larger or metastatic, and then they're obvious at that point. Now, this is another example that I'm showing to also illustrate the importance of multi-phase imaging. So this is a patient with pancreatic NET that when they got their multi-phase imaging, the primary tumor is very large and it's enhancing, and we see it quite well. It's going into the vessels. However, there is also a metastatic lesion to the liver. So we see this metastatic lesion on the arterial phase, and then on the venous phase is totally occult. It had washed out by that time. So that's why it's important to get multi-phase imaging on the abdomen for patients with neuroendocrine tumors. Now, how about MRI? When do we get MRI and what could it be helpful for? So MRI for liver and pancreas is really good, and for bone marrow. So if there are lesions in the bone on CT that we're not sure of, MRI can help characterize. MRI has the advantage of having multiple sequences, And each sequence shows a certain characteristic of the tissue. So on the enhancement sequences, they behave very similar to CT, but there are a couple of sequences on MRI that are particularly helpful to deliver. Diffusion weighted images, which is on the bottom right, is one of those sequences on which neuroendocrine tumor is more obvious. So sometimes lesions that can be occult on other sequences, they show up on this one. And one tool that's particularly helpful that also a lot of people probably have heard of is EOVIST, MRI with EOVIST. So EOVIST is a hepatobiliary specific contrast agent. So what that means is that the normal liver cells are going to take up this contrast dye and they're going to hold on to it. So basically when we image at delayed phases, the liver, the normal liver, is going to retain this contrast, and that's why the normal liver looks bright. Metastatic lesions are not going to retain the contrast and they're going to look like dark holes. And so here we have this metastasis that we're pointing out to by this green arrow. And so on the arterial phase, we have sometimes like blush around the lesion that makes it look a little bigger. But on the hepatobiliary phase, on the delayed phase with EOVIST, we can accurately measure liver metastases. And so this is particularly helpful for liver dominant disease. If we want to follow up with time, we'll be able to follow up with reproducible measurements or for surgical planning. So this is another case that we're following with MRI EOVIST, and you see how we see the lesions clearly, and the margin is much well demarcated on the EOVIST phase, which is the bottom phase. And this is another example where we were able to detect this 3 millimeter metastasis in the left liver lobe. So this is basically the MRI with EOVIST is the most sensitive to detect small liver metastases. Now, does that mean that everyone should get an MRI with EOVIST? Probably not if the lesions are well seen on CT and an MRI is not needed, but for indications in which it's really important to detect these small metastases or to very accurately follow up the liver lesions, MRI with EOVIST could be really helpful. So now let's get to our PET scans. So somatostatin receptor PET or Dota-tate PET has completely replaced octreoscan, as it should, because it's a much better modality to evaluate neuroendocrine tumors. So we do have a couple of tracers that are FDA approved and also commercially available to us in the US, and those are the gallium dotatate and the copper dotatate. A third agent, gallium dotatate, is FDA approved but is not available commercially. So in one word, basically, if we want to compare them, they're considered clinically equivalent. So there are minor differences between them, but overall, they all do a great job in evaluating neuroendocrine tumors. So the concept behind somatostatin receptor PET is that we have somatostatin receptors that are expressed on the surface of neuroendocrine tumor cells, and then we have this compound, which is our imaging agent, that has a vector that's going to come and attach to the somatostatin receptor. And we label this vector using a linker or a chelator with a radionuclide. And radionuclide is what we're going to be able to image. And that's what's going to allow us to see the distribution of neuroendocrine tumors throughout the body. So we could label with a diagnostic radionuclide like gallium or copper, but we could label the same compound as well with lutetium, yttrium, or actinium and treat neuroendocrine tumors using the same concept. So this is basically an illustration of how PRRT works, in which the lutetium dotatate is going to link to somatostatin receptors, it'll get internalized, and then it's going to radiate the cells from the inside. So what are the differences between gallium and copper? So the main difference is the half-life. So basically the half-life is the time that the radionuclide needs to get to half of its radioactivity. So, and this time is 68 minutes for gallium, and it's 12.7 hours for copper. So the main advantage for copper here is this long half-life that's going to allow the distribution of copper dotatate to areas where they don't have gallium generators nearby. So if we want to distribute a radio tracer with a half-life of 68 minutes, then we can distribute it only to short distances, but copper dotatate allows distribution to much longer distances. So that's the main advantage, and it's going to allow for wider scanning windows. So basically with gallium dotatate, we image after 60 minutes. With copper dotatate, we do the same, but because of the longer half-life, if we image a little longer, we could actually do that. So that's the main difference. Now, how the two compare head to head? So this is one of the studies that compared to gallium tautotoc, which is similar to gallium dotatate, and it showed that on a patient base, so they were identical for patients, but then a little more lesions were seen by copper dotatate. So those are specifically the tiny lesions were seen better with copper. And this is because of some of the physics properties of copper versus gallium. So copper allows for a little better spatial resolution. Now, if you're a patient who's considering, should I get a copper dotatate or should I get a gallium dotatate? It really, there is no major difference. Just whatever is available near you that you could get, it'll do the job. So clinically, they're considered equivalent. For us, as physicians who perform these images, we're going to have to optimize our protocols for copper, which is something we talk about quite a bit to allow having good quality images with copper, which is a little trickier than gallium. But from a patient or referring physician perspective, there shouldn't be really a difference. So how do we prepare before somatostatin receptor PET? So before you got your PET CT, most probably you were told that you should stop somatostatin analogs, stopping them for short acting for 24 to 48 hours or for long acting for doing it at the end of the cycle. So is this necessary though? So the idea behind that is that we don't want the octreotide to go and compete for the somatostatin receptors. And if they compete, then they're going to block some of these receptors, so our imaging won't be as good. But in fact, studies show that that's not really the case. So, in patients who were scanned before and after they were started on therapy with octreotide, they showed that the uptake in normal organs, so we have less uptake in liver, spleen, and sometimes thyroid after we start octreotide therapy, but the uptake in the tumor itself doesn't go down. So basically, now we're changing this practice. We're not asking patients anymore to stop somatostatin analogs because it really hasn't been shown to help. And there are even more studies that basically show the same. So although it's still in the guidelines, it's really, we know now that it's not really accurate. So I'm going to show a few examples on how we use somatostatin receptor PET or Dota-tate PET. So for staging of neuroendocrine tumor, this is an example of a patient who came with this renal tumor. So this is the tumor in the right kidney. And before surgery, basically, we didn't know that this is a neuroendocrine tumor. But after this tumor was taken out, turned out to be neuroendocrine tumor. So the patient got a Dota-tate PET, and the Dota-tate PET shows this very tiny node that before the era of Dota-tate PET, we wouldn't have known that this is a metastatic node, but now this node is obvious on our imaging. And this patient went to surgery again. This node was taken out. It was shown to be metastatic NET. And now the patient has been followed. And so far, they are disease-free. Now, a lot of the sites of disease are much more obvious on somatostatin receptor PET or on Dota-tate PET compared to CT. And bones are one of these sites. So on this example, we see many bone lesions. And if you look on CT, they're completely occult. We don't see them on CT, but on somatostatin receptor PET, they're very obvious. So for cases like this, staging and follow-up with somatostatin receptor PET is very helpful. Now, sometimes patients present with metastatic neuroendocrine tumor, but we don't know where the primary is after CT imaging. So this is one such case where we see a mesenteric mass, and then we do our somatostatin receptor PET, and the PET shows clearly where the primary is in the small bowel. So, so to localize the primary when we have known metastatic disease but unknown primary on CT, this Dota-tate PET is super helpful. And of course, to select patients for somatostatin receptor targeted therapy for PRRT. So for PRRT to be helpful, we need to make sure that the tumor is actually taking up the agent, and that's what Dota-tate PET helps us evaluate. So we need uptake in the tumor higher than liver to be able to deliver PRRT. Now, if someone was imaged with gallium dotatate initially, can they get their follow-up with copper dotatate? Well, ideally, it's good to stick with the same agent to have like accurate and reproducible follow-up, but it is also possible to switch, and that's totally fine. And when we switched from gallium to copper, there were some patients who basically we switched following up to copper dotatate, and that's not really a problem. So this is a patient who was treated with PRRT, and our pre-therapy imaging on the top with gallium dotatate and our post-therapy imaging on the bottom. And we see that there is response to treatment and some lesions have resolved on post-therapy, which is a great response to PRRT in this case. And the last point I want to address briefly is the role of Fdg PET. So why your physician might ask for another PET if you already had a Dota-tate PET done? Well, because Fdg gives us a totally different information. So Dota-tate PET is going to tell us where these tumors that are expressing somatostatin receptor, where are they located? And those are typically the well-differentiated ones. But sometimes tumors can be more aggressive and they're going to lose this expression of somatostatin receptors on their cell surface, and they're going to divide quicker when they do that. So FDG is helpful to detect these particular tumors because it detects the aggressive behavior. It detects tumors that are proliferating quickly. So I like to think of these neuroendocrine tumors along this spectrum, where we have, like, on the far left, the well-differentiated ones in blue, and those are the ones that are going to express dotatate and are going to be completely negative on our FDG. And this is an example on the left side of the screen. And then we have the very poorly differentiated ones on the far right of the screen, and those are the ones that are going to show up on FDG and are completely negative on dotatate. But then we have in the middle of this spectrum tumors that are heterogeneous, or they might express different level of somatostatin receptors and FDG uptake. And for those tumors that are in the middle, and some of them are also well-differentiated tumors, the uptake of FDG has been shown to correlate to worse prognosis. So basically, FDG is going to tell us which disease is actually the most aggressive that's going to show a poor prognosis. So some patients can have heterogeneous disease on both. Like, for example, this patient with a grade 2 PNET, and they have a lot of disease that we see clearly on Dota-tate PET, but we have some liver lesions that are more aggressive and that we see on FDG PET, but not much on Dota-tate. So basically, that's how both agents are going to give us complementary information to be able to evaluate the tumor overall. So this is an example of how we can use this clinically. So this is a patient who was referred to us. If it was an outside referral for consideration for PRRT. And so if we look at the first Dota-tate PET that was done, which is on the left side of the screen, there is definitely metastatic disease to the liver. And then 3 months after, and at this point when the patient was referred to us, the disease has progressed a lot. So we could see a lot more bone disease, and we could see that the liver is more evolved. However, on the left side of the liver, on the left aspect of the liver, we see that the liver has enlarged from before, and it's not showing somatostatin receptor. So basically, that's a red flag to us on CT that there might be poorly differentiated disease that we're not detecting on somatostatin receptors. So at that point, we got our FDG PET shows this disease in the left lobe of the liver. And so this is poorly differentiated disease that's not showing somatostatin receptor. So that's how both scans can be helpful at the same time. So here I should say that not everyone should get an FDG PET, but if we're seeing any lesions that are suspicious for higher grade disease that has lost somatostatin receptor, then we ask if possible to get an FDG PET to be able to evaluate these lesions that we're concerned about. With this, I come to the end of my talk, and those are my take-home messages. So it's important to do multi-phase or triple-phase imaging with RCTs or MRIs performed of the abdomen. MRI with hepatobiliary specific agent or EOVIST is very sensitive and accurate to evaluate liver metastases. Our Dota-tate PET is our gold standard for well-differentiated NETs. Gallium and copper are considered equivalent, and FDG PET is going to give us complementary information to Dota-tate and is going to basically detect more aggressive and more disease with worse prognosis. Thank you very much for having me, and I'm happy to take any questions.